working individuals. Today you are in one of the brand new rooms in their brand new Village Hall. And on behalf of the Village of Arlington Heights and each one of its citizens, I welcome each and every one of you. The Village of Arlington Heights has a motto, and that motto is, "We are the city of good neighbors." And in the spirit of that motto and of those words, I'd ask that we keep that in mind as we conduct the meeting this afternoon. It is now my pleasure to introduce Congressman Mark Kirk.
Thank you guys all for coming. Isn't democracy grand? Can we have a round of applause for the Arlington Heights team and Mayor Mulder and her team? I want to all welcome you here. This is the fourth traditional town hall meeting that I've had. We had one just previously in Wilmette on this very subject. We've also had 4 tele-town hall meetings, and we'll be having those as well. So this is actually my 8th town hall meeting. Now, because demand was so great, we're actually having 2 town hall meetings today. This one starting at 3, and then the second one starting at 4:30 to make sure that we can hear from as many folks as possible. I will say that we wanted a larger room, but school is starting next week. Several of our gymnasiums, for example, were getting the floor waxed in preparation for school. And we checked out with the library, but they were under construction right now. And so we want to thank the Arlington Heights team for having us. Let me welcome you to an open, public, free of charge town hall meeting today. Now, we want to thank everybody. This was on a first-come, first-served basis. I don't know what your views are on this. I'll hear this, but I'll say that everyone is welcome, whether you're a carnivore, a vegetarian, or agnostic here. And what I'd like to do to focus the attention is briefly go through 2 quick presentations to focus our debate. I will like the discussion to be in what I would call 10th District rules, which is that we respect everyone's opinion and we're not interrupting anyone because we want to hear from both sides or folks that haven't made up their mind and just want to hear from their elected representatives and their neighbors. First, if I could go to the first slide here. I am very concerned that we make sure that we preserve the quality of care in the United States. And many of you remember in the 60s hearing from a friend or family member who got a diagnosis of cancer. And back then, it was the beginning of the long goodbye. One of the things that has gone right with American healthcare is cancer survival rates. And you see it here across prostate, bladder, breast, and uterine cancer. And what is surprising is in the United States, the survival rates are higher than in Europe. When you look at the next one, overall you can see that the district is fairly dramatic for women. 63% of American women now survive cancer, 56% of European women. But according to the Lancet, and by the way, for those that don't know, the Lancet is the most respected British medical journal that issued this study. The survival rate for men is very dramatic. That's particularly because of prostate cancer and its treatment in the United States of America. And so you can see that still more than half of European men die of cancer. But now 2/3 of American men will survive. If we go to the next one of the reasons why we are probably better at cancer is especially when you look at pap smears and mammograms, very important early detection for women. And you can see here that the numbers for the United States are higher than for Canada and the United Kingdom especially. And as you all know, early detection is critical to survival. And we want to make sure that we preserve that. If we go to the next one, you can see here that when you look at high-tech medical procedures in the United States, this is something that is now somewhat restricted in some other countries. Dialysis is probably the most dramatic. Now, with Congressman Jim McDermott, I am the co-chair of the Kidney Caucus of the House of Representatives. So I spend probably more time on kidney disease than any one disease. And there you can see that dialysis is not as available in Britain, with some disturbing restrictions for older Britons. A similar situation appears to be the case for coronary bypass, and many of us know in heart disease that coronary bypass can give a decade or even 2 decades of productive life, and you can see the differences between our two countries. And of course, coronary angioplasty, much less invasive and yet substantially better for the United States of America. In this debate, many are worried about waiting times. And as you can see here, for the waiting times, 4 to 6 weeks to see a specialist, or 4 weeks to see a specialist doctor. What this chart shows is Germany, even slightly better than us. About 23% of Americans are waiting a month or more to see a specialist. But now 60% of Britons and 57% of Canadians are waiting a month or more. That's very worrying because care delayed is care denied. And imagine getting a fairly fearsome diagnosis from your oncologist or your cardiologist and then having to wait that long. And of course the corresponding morbidity would be higher because of that wait. If we go to our next one, you can see that there are some things that Americans need to change. For example, smoking and obesity. The American diet needs to change in a considerable way. And this, I would say, is where we have substantial bipartisan agreement with the President that rewarding good habits and reducing obesity can help lower costs. And you can see the numbers are fairly dramatic there. Almost wants you, when you look at the Japanese number, it'll go on the all sushi diet, if you can see there. One of the key aspects of this debate is the uninsured. There's a 2002 number of 37 million, an average of 49 million. Right now, the Census Bureau reports 47.5 million Americans, or sorry, 47.5 million people in the United States have lacked health insurance at any time in the last year. As Paul Harvey would say, you have to look at the rest of the story. And the rest of the story shows that about 22% have only briefly been uninsured, another 25% lacking insurance for 6 to 11 months, and then 53% of that number being sort of the longer-term uninsured. If we go to the next chart, we also worried that for some of the uninsured, by this number 19%, you can see that they're making considerably above the average income of the United States. The average income of the United States, by the way, is $56,000. And the question is, should we tax people making above average, or should we provide a subsidized benefit for people making above average income with the tax dollars of people making below average income? And is that fair? So, next, when we look at the uninsured, we see a number of programs are available for those who lack insurance. But as we have seen, in many government programs, we have a tough time getting folks that are already eligible for government programs to sign up. This is particularly evident in Massachusetts from their program, in which a number of folks, about 1 or 2% of patients, will not report stable identity, stable address, and will not report for follow-up appointments. That shows that for that upper percentage point, the insurance model may be breaking down, which is why public health clinics are so important to reach that community of folks. When you look at the next one, obviously we contribute quite a lot to health care for the uninsured right now. And the question is, among all those programs that you see, are they properly coordinated? Or could there be a better way? With $34.6 billion by this 2004 number, which is, by the way, substantially more than the gross domestic product of many members of the United Nations. Could that be provided?